Welcome to this detailed exploration of pelvic floor muscles and their biomechanics. I'll be covering the anatomy across the layers, mechanical properties, load transfer mechanisms, functional roles, neuromuscular control, and clinical applications in dysfunction and rehabilitation. This multi layered system acts as a funnel shaped muscular hammock spanning the pelvic outlet, essential for support, continence, and stability. The pelvic floor has three main layers. The superficial layer includes the bulbospongosus, ischiocavernosus, superficial transverse perineal, and external anal sphincter muscles. The levator hiatus measures about 20 square centimeter in nulliparous women. Moving on to the intermediate layer or the urogenital diaphragm, the pubovisceral muscle comprises 70% type 1 slow twitch fibers and 30% type 2 muscle fibers. Key structures are the deep transverse perineal, external urethral sphincter, and compressor urethrae anchored at the perineal body which connects six muscles. The deep layer features the levator ani, pubococcygeus, puborectalis, iliococcygeus, and coccygeus or ischiococcygeus, with average thickness of zero point 0.8 to 1.2 centimeter on ultrasound. As shown in the image here, this layered structure provides a comprehensive pelvic support. The mechanical properties of the pelvic floor muscles reflect their capacity to resist, generate, and adapt to physiological loads. The passive stiffness ranges from approximately 10 to 30 newtons per meter. This behavior arises from the viscoelastic properties of collagen and elastin within the connective tissue matrix and is typically increased in Paris women due to structural remodeling. In contrast, active force generation can reach up to 220 newtons during maximal voluntary contraction. However, this capacity progressively declines with advancing age and parity, reflecting the changes in muscle integrity and neuromuscular efficiency. The pelvic floor muscle demonstrates significant extensibility with elongation at break ranging from 2.5 to 3.5 times the resting length. This property is particularly critical during the vaginal delivery, where tissues may stretch up to 3 times their baseline length. Importantly, these tissues exhibit strain rate sensitivity, characteristic of viscoelastic materials. Slower loading rates result in greater deformation, a principle that is highly relevant during childbirth and prolonged loading conditions. Collectively, these properties highlight the dual requirement for both structural and adaptive resilience and flexibility. Let us discuss about the load transfer through intra-abdominal pressure, a concept that is highly relevant in pelvic health. Importantly, intra-abdominal pressure or IAP is not just about spinal stability. It is a dynamic pressure regulating system that directly influences pelvic floor function, continence, pelvic organ support, and lumbopelvic load transfer. To begin, let us look at the abdominal cavity. It functions as a functionally enclosed, dynamically regulated viscoelastic system. It is bounded by the diaphragm superiorly, the pelvic floor inferiorly, the abdominal wall laterally, and the lumbar spine posteriorly. Now, it is important to clarify this system is not completely closed. It is continuously influenced by breathing mechanics, abdominal wall compliance, and pelvic outlet dynamics. The hydraulic amplifier model helps us to understand how the system works. When the diaphragm contracts, it moves downward, increasing the intra-abdominal pressure. The abdominal contents behave as a viscoelastic mass, allowing pressure to be transmitted in multiple directions. However, this transmission is not uniform. It depends on muscle activation, facial tension, boundary compliance, and as well as you have to understand that intra abdominal pressure does not directly support the spine. Instead, it increases the trunk stiffness, reduces the mechanical demand on spinal muscles, and enhances the force transfer between the thorax and pelvis. From a pelvic floor perspective, the pelvic floor is central to the system. Its role is not just support. It modulates intra-abdominal pressure, resists downward displacement of pelvic contents, contributes to continence and load transfer. Functionally, it works through both eccentric control and concentric contraction depending on task demands. A crucial but often overlooked component is breathing coordination. In normal function, during inhalation, the diaphragm descends and the pelvic floor lengthens. During exhalation, the diaphragm ascends and the pelvic floor recoils. This coordinated movement is essential for efficient pressure regulation. Disruption of this relationship can lead to poor pressure management and increased pelvic floor strain. Another important concept is feed forward activation. The pelvic floor and the deep abdominal muscle activate prior to or at the onset of movement. This anticipatory mechanism prepares the body for load. However, in clinical populations, often we see a delayed activation, excessive bracing, or a poor coordination, which leads to inefficient pressure regulation. The Valsalva maneuver is actually a normal task specific strategy used to increase trunk stiffness during high load activities. However, in a pelvic health populations, poorly controlled Valsalva can increase a downward pressure and overload the pelvic floor. So, clinically, our goal is modification, not elimination. At this point, I want to emphasize a fundamental principle. Dysfunction occurs when load exceeds tissue capacity. This concept is central to understanding pelvic floor disorders. For example, in stress urinary incontinence, intra-abdominal pressure exceeds urethral closure pressure. This is often due to poor timing, reduced strength, and impaired coordination. Whereas in pelvic organ prolapse, it is essentially a load versus capacity mismatch over time. It results from repeated or sustained increases in intra-abdominal pressure and combined with reduced tissue support capacity. In case of postpartum dysfunction, the usually postpartum patients present with altered neuromuscular control, connective tissue changes, or reduced load tolerance, which affects their ability to regulate pressure effectively. So, we have to actually shift our rehabilitation approach significantly. We have to emphasize on pressure management, breathing coordination, pelvic floor timing, and functional movement training. So ultimately, rehabilitation should target in such a way isolated strengthening, excessive bracing, and uncontrolled breath holding is avoided. Let's briefly review the functional roles of the pelvic floor muscles. First, the continence. Continence is maintained when urethral closure mechanism effectively counter increases in intra-abdominal pressure. Pelvic floor muscles activate both anticipatorily and reflexively during activities such as coughing and sneezing. They also maintain a baseline resting tone, which contributes to passive continence. The next, pelvic organ support. The pelvic floor provides a dynamic supportive platform for pelvic organs. This support is achieved through a combination of facial suspension and active muscular control. Clinically, an increased levator hiatus area is associated with a higher risk of pelvic organ prolapse rather than a fixed cutoff value. The third, lumbopelvic stability. The pelvic floor works in coordination with the transversus abdominis and other trunk muscles, contributing to lumbopelvic stability and force closure mechanism. It also plays a role in modulating intra-abdominal pressure and may help reduce excessive lumbar loading during movement. Finally, sexual and reproductive function. The pelvic floor contributes to rhythmic contractions during orgasm, provides controlled resistance and relaxation during childbirth, and must be able to relax appropriately for penetration. Importantly, across all these functions, a key principle applies. Dysfunction occurs when load exceeds tissue capacity. So, overall, the pelvic floor is a dynamic, adaptable system essential for continence support, movement control, and reproductive function. Neuromuscular control of the pelvic floor involves coordinated voluntary anticipatory and reflex mechanisms. Cortical input via the pudendal nerve activates both endurance and fast twitch fibers, supporting a sustained tone and rapid continence responses. Voluntary control modulates reflex activity. The pelvic floor activates prior to or at movement onset, contributing to a lumbopelvic stability, while reflex responses to increased intra-abdominal pressure enable a rapid urethral closure. Overall, effective function depends on coordination rather than strength alone.